Thank you for joining the virtual patient symposium at the annual KCA meeting. I am Virginia Seary. I am a nurse practitioner. I work at Beth Israel Deaconess Medical Center in Boston, Mass, and I take care of kidney cancer and melanoma patients. And I'm going to be talking with you today about the treatments for advanced kidney cancer. And I should note this is a very general overview since we have a limited amount of time, but I know you'll be hearing from other clinicians as well about more details. So these are my disclosures. So when we think about treatments for advanced kidney cancer, there are different categories of treatment. And these are highlighted here. So immunotherapies are obviously a more recent player in the field of treatment, and very exciting data about them. Targeted therapies are also a mainstay of treatment for kidney cancer. And then we have combinations and, of course, clinical trials. I won't be going into detail about clinical trials because I know that there are other people talking in detail about them, but I will touch on them briefly at the end. So we'll touch on each of the three categories in a little more depth. I would like to say individualized treatment for kidney cancer patients is very important. And there are different factors that will affect what treatment is offered to you by your oncology team. So it depends on the type of kidney cancer you have or the histology of the kidney cancer. It also depends on the risk category of your cancer, which is something that your team will look at in terms of whether you have a higher risk cancer or a lower risk cancer. It also depends on the amount of cancer in your body. For instance, if you have a very small amount of cancer left after having had perhaps your kidney removed, you might be considered for active surveillance, just being followed closely without any treatment to get a sense of the pace of your kidney cancer. The location of the cancer also matters. For instance, if it's in a critical location where it could cause problems if it grows, the team might be more likely to start treatment on you than they would otherwise. On the flip side, if you have some cancer located, say, in just the soft tissues, not in any organ system, then again, surveillance might be chosen as the appropriate treatment. Another factor is whether or not you have symptoms from your cancer. So some patients have cancer in their bodies but feel fine and don't know that they have any cancer. If they weren't told that they did, they wouldn't know they had cancer, which is obviously a good position to be in. Sometimes those patients are, again, monitored closely rather than being put on treatment that could then cause them side effects. But if a patient has a lot of symptoms from their cancer, then treatment is clearly indicated and your team will try to pick the best treatment for you. And another factor to consider are any other illnesses that you have. If you have a couple of other problems with your heart or your lungs, that may impact what treatment your oncologist would like to choose for you in order to prevent problems from those other illnesses. And then the order of treatment differs from person to person. So sometimes patients with kidney cancer need 1, 2, or 3 different treatments sequentially. And if that happens, sometimes the treatment might be, a treatment started for one person at first might be different for a separate person based on those factors listed above. So there's no one route that we follow to treat patients. We look at them very individually. So let's start off with immunotherapy. These drugs work with the immune system to potentially slow or stop the growth of kidney cancer. They may cause tumors to become smaller, or in a minority of cases, to go away completely. And that, of course, is the gold standard. Immunotherapy takes longer to work, so it's important for patients and your oncology team to know and remember that. It's possible that at your first set of scans after starting immunotherapy, you may not see any improvement in your cancer. You may see that your cancer is the same or stable, as we call it. It's also possible that the cancer may look a little bit worse in that case. Many times the treating team will make a decision, if that's the case, if your scans look a little worse, as to whether to continue the immunotherapy or switch at that point. And some factors that go in here are, how are you feeling? If you're feeling well, or perhaps even better than you did before starting the treatment, many treating teams will continue the immunotherapy, hoping that over time, the immunotherapy will cause tumor shrinkage. That's an individual discussion to be held with you and your team members. But just remember that it does take longer for immunotherapy to work than other treatments. There are different types of immunotherapy. There are the checkpoint inhibitors, and that includes the anti-PD-1 checkpoint inhibitors, including nivolumab and pembrolizumab, and the anti-PD-L1 checkpoint inhibitor avelumab, and then the anti-CTLA-4 checkpoint inhibitor ipilimumab, which is used in combination with nivolumab for treatment. And then a third category would be the cytokines, including interleukin-2 and interferon. And these substances are naturally produced by the body, but can be given in high doses to create an immune response. Now, I should note that interleukin-2 or high-dose IL-2 is still used, but it is used less frequently now that we have the immune checkpoint inhibitor immunotherapies available to us. If a patient is going to receive high-dose IL-2, it should be given in a center that does this all the time and is able to manage the side effects, which may be toxic, of this treatment. In terms of interferon, I would say that is rarely used these days in standard treatment for kidney cancer. Now, how do the immune checkpoint inhibitors work? The immune system has natural brakes to prevent it from attacking healthy cells. What the immune checkpoint inhibitors do is they interrupt those natural brakes, and they allow the T cells from your immune system to go out and attack or fight the cancer cells. This is also the mechanism for immune-related side effects. So if the T cells go after your cancer cells, but also after your healthy body tissues, which can happen, you may get some of those immunotherapy side effects that we'll touch on in a little bit. Now, the administration schedule for the medications varies. The anti-PD-1 and anti-PD-L1 checkpoint inhibitors are given IV, and they can range from every 2 to 6 weeks, depending on which one you're treating with. And they are given as an outpatient. So these are not drugs that you have to come into the hospital to get admitted for. You might come in to the oncology clinic to get those. Likewise, the anti-CTLA-4 checkpoint inhibitor ipilimumab is also an outpatient treatment. It is given IV every 3 weeks, and it's typically scheduled for 4 doses in combination with nivolumab. That being said, some patients cannot get all 4 doses of the combination. Some patients may get 1 or 2 and then develop side effects that make us pause and decide whether we should continue the treatment or whether we might consider transitioning just to treatment alone with the nivolumab. And this is typically done if a patient does get through the 4 doses of the combination, they then typically continue on just the nivolumab, which can be given every 2 or 4 weeks IV alone without the ipilimumab. And then the cytokines, interleukin-2 is given IV every 8 to 12 hours, and that is given as an inpatient. And the treatment is typically over 5 days. Patients need to be in the hospital for about 7 days when they get that treatment. And the treatment is typically given 1 week inpatient, and then they have a 1 or 2 week rest at home, and then they come in and get a second week of treatment, and that is considered 1 cycle of therapy. And interferon, when it was being used, this was given by injection into the subcutaneous tissues or into the muscle 3 times weekly as an outpatient. And it is currently approved in combination with a targeted therapy called bevacizumab. Immunotherapy side effects. We spend a fair amount of time talking about side effects when we start people on these medications because they can be serious. So prompt recognition of side effects and treatment is really critical. So it's very important when you start these medications that you have a good communication plan set up with your oncology team, whether that's uh, overnight or on the weekend, a person that's on call that you could reach if you develop a problem, somebody who knows how to manage immunotherapy side effects. Also, when you first start treatment, it's very helpful if you carry a wallet card with the name of the drug or drugs that you're getting, so that if you do have to go into the emergency room or urgent care, or you go see your primary, you can pull out that wallet card and show them what immunotherapy that you're on, so that they're aware as well of what they should be looking for, or if you're developing a side effect, it might connect to them that this is from the immunotherapy as opposed to a different problem. Generally, immunotherapy is well tolerated, but as I said, if side effects occur, they can be serious. So if you're having a serious side effect, obviously we want to figure it out quickly so that we can treat it quickly and minimize the discomfort for the person. Immunotherapy combination, the ipilimumab and nivolumab, has a higher likelihood of side effects, which makes sense when you think about two drugs being given at the same time. And again, as I mentioned, the side effects from immunotherapy happen when the immune therapy or the T cells attack normal body tissues. It's important to note that any part of the body may be affected, and I mean any part. So I think when I talk to patients about this, I basically try to go head to toe and talk about what might be affected. So it could cause issues with your brain or your pituitary gland or your eyes, your thyroid gland. What the medications do is they can cause inflammation in those areas. And inflammation can cause symptoms or side effects. So if you're on treatment and suddenly you're having new visual problems, it's important to let your team know so that you can be evaluated by an ophthalmologist to see if you're having inflammation in your eyes that needs to be treated, perhaps with steroid eye drops. Continuing on, you could have skin inflammation, and skin is both your external skin and also the lining of your mouth or anywhere along your gastrointestinal tract. So you can sometimes get inflammation in the esophagus or your stomach or the small or large intestine. And again, that inflammation can give you symptoms such as nausea, vomiting, or diarrhea, and can lead to serious side effects, including colitis. Additionally, occasionally these medications will affect your heart and cause heart muscle inflammation or inflammation of your liver or your kidneys or your pancreas. Sometimes we know that these are happening or we suspect they're happening based on the side effects. And sometimes it's a blood test that we check when you come in to see us that tells us you have some inflammation. Obviously, it's good if you can pick that up sooner rather than later, but there are times when you don't know that it's happening until a blood test comes back as being abnormal that gives us a clue that this issue is happening. Likewise, you can develop inflammation of the joints or muscles or your nerves. Anything that's different, I tell my patients, anything that is different once we start the immunotherapy, I want to know about, because I first want to rule out that it's an immunotherapy side effect, because those are treated so differently, and it's important that they're recognized promptly in order to get them treated to go away completely. The mainstay of treatment is typically steroids, which calm inflammation. The exception to that rule is if you develop thyroid gland abnormalities. That's typically treated with supplementation of thyroid hormone. Some of the other hormonal problems that you may develop may also be treated with steroids. Sometimes patients are naturally concerned that receiving steroids could take away the positive effect that has been occurring with their cancer, meaning are we going to reverse the improvement seen in their cancer because we're giving them steroids? We also, as a medical community, had concerns about this early on, but the data now suggests that the positive effects against your cancer are not taken away if we need to give you steroids. So again, it's very important to let your oncology team know right away if you have any new symptoms. Let's move now to the targeted therapies. This class of drugs works by interrupting a step in cancer cell growth. These medications often slow the growth of cancer cells, but don't typically eliminate them completely. They tend to work more quickly, and so if you are having symptoms from your cancer or you have a lot of cancer in your body that is worrisome or in a critical organ, these treatments might be initiated in order to get a quick response. Most of these are given orally and are given as an outpatient. Some of the different targets that are important in kidney cancer include the vascular endothelial growth factor, or VEGF pathway. This pathway promotes blood vessel formation, which causes cancer cells to grow. If we are able to inhibit VEGF with one of these targeted therapies, we can decrease blood flow to the cancer cells, causing them to shrink or stop growing. Another target is the mechanistic or mammalian target of rapamycin, or MTOR pathway, and this promotes cancer cell metabolism and growth. So inhibiting the MTOR pathway can interrupt this process and cause tumors, again, to stop growing or to shrink. Now let's look at the two categories and give you some examples of these medications. And I am using generic names, not brand names, so I apologize if you don't recognize these names. The VEGF inhibitors include cabozantinib, axitinib, pazopanib, sunitinib, lenvatinib, bevacizumab, which is given IV, or sorafenib. All of the other agents other than bevacizumab are given orally. The mTOR inhibitors include two, which are everolimus, which is given orally, or temsirolimus, which is given intravenously. And again, to go back to which one does your team choose, we go back to those issues of, well, what have you had for prior therapy, or what other illnesses do you have that might impact the choice of these medications. Some of the VEGF inhibitor side effects that can be seen include fatigue. This is a very common one, actually, for most of our treatments, unfortunately. There are ways to combat fatigue, but I would say that it's probably one of the more problematic side effects that we see. In general, patients will do better if they can get adequate rest, which sometimes is a challenge if they're having other side effects, or trying to incorporate a little bit of activity, which I know is a challenge if you're not feeling well, but if you can do a little bit of physical activity, sometimes people actually sleep better, and then sometimes their fatigue can improve a little bit. Another side effect, which is concerning with these agents, is high blood pressure. So if a patient already has high blood pressure and they're going to be starting a VEGF targeted therapy, we need to anticipate that that blood pressure might go up significantly. And they may need to have, if they are already on medicine, they might need to have a second or perhaps even a third agent added to control their blood pressure. If a patient has no history of high blood pressure, that's a good thing, but they still may end up needing to go on a blood pressure medication with these agents. So it's important to keep an eye on that. This drug class also affects the gastrointestinal system quite largely. It can cause nausea, it can cause vomiting, they can cause a loss of appetite, which leads to weight loss, which we don't like in our patients. It can cause taste changes, and therefore, again, the patient may not eat as much and lose weight. Diarrhea is also a problematic issue. So sometimes medications are needed to treat nausea or to stimulate appetite or to help manage diarrhea, or think about dietary changes that can help with diarrhea from treatment. Hand-foot syndrome is also called PPE, or palmar plantar dysesthesia. It is a very problematic side effect that can sometimes occur with these agents. It involves redness, pain, or skin blistering on the palms of your hands or on the soles of your feet. It tends to happen more commonly when you're using your feet or your hands a lot. So if you are out raking leaves, for instance, for an hour or two, you may notice the next day that you've got pain, redness, or perhaps even blistering on the palms of your hands. And it's important to recognize that quickly and consider taking a break from the treatment and using supportive therapies, which might include topical creams or perhaps some gel insoles for your soles of your feet, or obviously avoiding more raking or more work with your hands, or avoiding hot water on your hands or your feet. So this is one of those problematic side effects that you want to tell your team about pretty quickly, so that we can determine whether you should hold treatment at that time. And what can be done is treatment is held and those changes in your hands and feet improve, and then we will restart treatment, sometimes with a dose reduction. And let's just touch on that a little bit. Many patients get worried if we're lowering the dose of their drug, thinking that the treatment might not be as effective. And I try to encourage people that we can sometimes go up or down on the dose as needed. And sometimes, since everyone's individual, a dose that one person needs might not need to be as high for another patient. So sometimes that lower dose will work just as effectively to control your cancer. So don't hesitate to tell your team about side effects because you're worried that we'll lower the dose. And it certainly is shared decision-making with you that we want to go over things and consider whether we should hold therapy or consider a dose reduction. Some other side effects include hair color changes. So if you have dark hair, you may notice that your hair gets lighter or may even become white. And it can affect the thyroid glands, just like the immunotherapy. It can cause cause hypothyroidism or an underactive thyroid gland, and that is treated with thyroid hormone replacement. MTOR inhibitor side effects also include fatigue and weakness, can include rash or mouth sores, which can be particularly problematic for many patients. You have a higher risk of infection, and you can have low blood counts, and those two don't go well together, meaning if you have low blood counts and get an infection, that's particularly difficult. You are more at risk for an infection with lower blood counts. And again, the GI side effects, similar to the VEGF side effects, are extensive and can include nausea, decreased appetite, and diarrhea. Patients on mTOR inhibitors may also notice swelling. You might notice some swelling in your ankles, or a very distinct side effect from this class of drugs includes lung inflammation. It doesn't happen often, but when it does happen, it's important to recognize it early on so that we can treat it. The things that you might notice when you're taking these medications that could suggest lung inflammation would be cough, shortness of breath or worsening shortness of breath. Things that we as clinicians will look at would be lower oxygen level that we check when you come in. And if we notice that it's different than it has been, it's lower, we might think about getting a chest CAT scan to look to see if we can see inflammatory changes on that scan that would suggest there's an issue. This class of drugs is also unique in that it can cause abnormal lipid and blood sugar levels. So sometimes you will need to go on cholesterol lowering agents or on medications to lower your blood sugar. Now, managing your targeted therapy side effects, I touched a little bit on this in the prior slides, but again, notify your oncology team right away for side effects. The sooner that we can address them, hopefully the better we'll be able to treat them. It's important, if you can, to try to obtain a home blood pressure cuff, and it's very helpful if you can track that daily or every other day for us, just so that when you come in, sometimes people get more anxious coming into clinic and your blood pressure can naturally go up because of that. So if you bring in your record with you that shows your blood pressure is generally doing fine, but you're just a little nervous coming in and therefore your blood pressure is up, that's reassuring to us. Likewise, if you are having a low blood pressure, it's also important for us to know that. And one of the things that I should have mentioned when I was talking about holding your therapy. If we do hold your therapy for a side effect, we need to remember that your blood pressure might drop. So you may not need as many blood pressure lowering agents. If you needed to be on 2 or 3, you might need to be on just 1 or 2. So it's also helpful in that way. If you're holding your treatment, we can monitor your blood pressure to make sure it doesn't go low while you're on a treatment hold. And as I said, we will hold treatment until those side effects are better and then restart. Supportive medications are available for most of the side effects, whether that would be to address fatigue, medications that can help with giving you a little bit more energy, medications for nausea or diarrhea, mouthwashes that can help if you're getting mouth sores or irritation, or topical creams for rash or for the hand-foot syndrome. Let's move now to combination therapies, because these have recently become more popular and we're using them more. And the theory is obviously if 1 treatment is good, then 2 is better. And I said sometimes because that's not always the case. And sometimes, as I note down below, side effects might be more pronounced if you're getting more than 1 therapy. But it makes sense that if you hit the cancer in different ways, it might make the treatment more effective. So if you go at it from both an immune side and a targeted side, you might hit the cancer in 2 different ways and cause the tumors to shrink more extensively. The types of combinations that we use in kidney cancer could include 2 immunotherapies, and those would be ipilimumab and nivolumab. It may include 2 targeted agents, which would be lenvatinib and everolimus. And then it can also include 1 targeted agent and 1 immunotherapy. And those combinations include pembrolizumab and axitinib, avelumab and axitinib, and then bevacizumab and interferon are also one of the treatments for kidney cancer, but again, used much less frequently today, given that we have other options. The side effects of combinations are a little bit challenging because they often will overlap, so it's not always clear what drug is causing the side effect. So as clinicians, it's a challenge for us sometimes to decide, is the diarrhea from colon inflammation or is it the diarrhea that we see with a targeted therapy? Our general approach to trying to sort this out is to hold the targeted therapy first, and most of the time these are oral therapies. So they tend to clear your system a little bit faster. The immunotherapies are given IV and given, every few weeks, so those stay in your system longer. So if we have a person on a targeted therapy in combination with an immunotherapy and they get a side effect, we'll often hold the targeted therapy, the oral targeted therapy first. And if a patient's symptoms improve, then we can assume that that was from the targeted therapy and not the immunotherapy. On the opposite side, if we hold that oral therapy and the diarrhea does not improve, we then have to think about the fact that this is probably immune mediated, and we will need to consider further tests such as a colonoscopy or steroid treatment to help manage the side effect. So again, the same premise, try to keep your treating team updated about any side effects that you're having so that we can catch them early and try to address them so they don't worsen. And just a brief note on clinical trials. I know you're going to have a separate presentation about clinical trials, but I'd like to note, advanced kidney cancer is hard to cure. However, we have had major progress in the past 15 years, and we hope to continue to build on that progress. We need new treatments and new combinations to help more patients, and trials often offer a treatment that's not otherwise available, so it can expand your treatment options. Clinical trials most definitely improve care for kidney cancer patients. All of the treatments that we've just talked about were in clinical trials, and that's how they got approved for use in kidney cancer patients. And so if there is a clinical trial available, talk to your clinician about it and find out the risks and the benefits and the pros and cons, and perhaps consider enrolling in a clinical trial so that we can further advance the field and help more patients. And I'd like to just shout out to the patients and families and thank you for participating in clinical trials all these years, which have gotten these treatments approved. Please know that you have paved the way for many others to be, for it to be possible for them to get these treatments, and you have helped so many people. So we very much appreciate it. Thank you.